Thanks for the insight on the similarities of our health system with others. What is the main drivers limiting hospital accessibility? Why do patients wait for hours to be seen in the emergency department? Why do we have what we coined here in Ontario, hallway medicine?
In order to address this, and I would comment on Canada specifically later on, in order to address this, I would like you to look at the slide on the screen. The green line that you see on that slide is daily bed occupancy. And by the way, that's a real hospital. Any hospital in Canada would look like that. Again, the green variable line is the daily number of occupied beds. You see how variable it is. When the hospitals are well managed, you know, this difference between peaks and valleys could be 20%, 25%. Otherwise, it could be much higher. So let us consider what happened at the hospitals. And that is probably the most important part of our conversation. How do you get to the hospital? How do patients get to the hospital? There are three main portals of how patients can get to the hospitals. The main portal is admission through the emergency department. Those admissions are typically over 50% of all hospital admissions. The next one is admissions, elective admissions. Those admissions to the operating room when people need the surgery. Those are also admission to the catheterization lab when the patient have a problem with their heart. These two parts, elective admissions, are typically significantly less than admissions through the emergency department, with a few exceptions, like, for example, Shouldice Hospital in Canada, when they do just hernia. But that's, again, it's exception rather than the rule. The remaining admission, and that even smaller portion, are direct admits from the primary care physician office to the hospital. Those are smaller than both of these, each of these that I named. So again, the main source of the admission, the main portal to the hospital's emergency department. Every patient in Canada, US, or UK is very much, if you brought your loved ones or you came to the emergency department, you must be very familiar with excessive waiting time to get to the emergency department. We should later on consider why you have that. But at this point, let us ask ourselves a question just based on our common sense. You see this variable line. The red dashed line is how we use to staff all the beds. So we figure out what is the maximal number of patients in a bed, and we staff all these beds correspondingly. That was many, many, many years ago, but your grandparents, I'm sure, still remember those good times, old good times. We are not there yet. We cannot afford it because the main cost, the main portion of the hospital budget is staffing the floors, is paying your nurses. So we figure out that we hit the ceiling and we no longer can afford staffing at the peak and having everything below being a waste. So we started staffing at the middle, staffing at the average bed occupancy. For example, if any Canadian hospitals are planning to budget their staffing, the number of nurses they're going to pay for the next year, they look what is the average bed occupancy for 2021, and that would assign this money for the 2022, but we never had the average. What happened when we're above the average? And that happens every other day, if not more often. There were dozens and dozens of publications documenting that when we have these peaks, when we do have insufficient nurse staffing, that results in inflated mortality, medical errors, readmissions, overcrowded emergency departments, et cetera, et cetera, et cetera. When our bed occupancy is below this average, then we have a waste. And that was pre-pandemic. That is very important, that what was going on in Canada before the pandemic. What do we have to do if we have these peaks and valleys? Let's use our common sense and ask ourselves, why do we have these peaks and valleys? Look, if you go on the street and ask any person, you have the three portals. The main is emergency department, the next elective surgical admission, the next direct admission, medical referrals. Which one is the main contributor to this variability? Everybody in the right mind would say that that's emergency department. Why? Because the volume is the highest and the demand is unpredictable. We do not know when people would come to the emergency department. Again, I'm talking about the period pre-pandemic. So that's what would people say based on their common sense. But let me share with you a secret, that the common sense and the way we deliver healthcare are not always compatible. So if you look at this plot that you see, this variable line, I can tell you what is the main reason in most, if not all, Canadian hospitals that brings us to this kind of variable bed occupancy. Those are elective admissions, scheduled surgical admissions. So what it means, that it is easier for me to predict when somebody will break the leg than when elective scheduled surgery would take place. That I'm not exaggerating. So that's what we have. Now let's consider what are the consequences of that. Why operating room is so important. And if you look at the second slide, I call typically our operating room is the Vatican. It's a state within a state. They schedule their admission, whatever they believe is right for them, their patient, whatever. Typically, the surgery, most of the surgery is taking place on Monday and Tuesday. And if you're a patient, and if you want to have a surgery, my strong suggestion to you would be to try to have it in the morning on Monday or Tuesday. Surgeons are fresh, the hospital is not full, and you're in a good shape. What would happen otherwise? Whether you come to the surgery or you come to the emergency, let's start with emergency. If you come to the emergency department and you sit and wait and wait and wait and wait, I look at the Canadian data before the pandemic, and if the decision is made that you should be admitted, it may take hours and hours before you get the bed. Why? What is, we didn't anticipate that we have a patient on Monday or Tuesday. We are surprised that we have snow in January. That happens always. So why do we have this waiting? One answer would be, we should build more beds. How many? As many as we can. That's not an answer though. So why do we have this waiting? The reason for that is our problem, our rich cousin surgery is doing surgery on Monday, Tuesday, and by Thursday, the hospitals are full, even pre-pandemic. So the poor cousin in the emergency department should sit and wait there. That's what is going on. That is why you are waiting for so long in the emergency department on some days and less on other days. So what happened? Are you getting more sick on a particular weekday than another? Are you breaking your legs more often on Thursday than on Wednesday? The reason are elective admissions, and you should know that. Now, that's not the end of the story. Let's say you came to the emergency department with an orthopedic problem. So they say that you should be admitted for surgery or otherwise for some medical treatment into orthopedic units. Or thoracic surgery. Would you be admitted to thoracic unit? Or urology or whatever? The answer is no. Why not? Because people are mean-spirited? No, people are not mean-spirited. I know quite a few frontline Canadian clinicians, surgeons, physicians, nurses. I've never seen the one who is not absolutely committed to provide the highest possible care. So that's not their fault. Whose fault is that? That they are committed and yet we're in trouble. They're trying to get you admitted, but if the hospital is full, what kind of choice in the emergency department they have? They can admit you to the right floor. If you're an orthopedic patient, they would like to, after the surgery, or if you're a medical patient, to admit you to the orthopedic floor. But what if all the beds are occupied by elective surgical patients that had been done prior to your arrival? Then you'll be placed wherever is possible. I read in newspapers, I cannot confirm that, but I read in the Canadian newspapers that sometimes people are being placed in, I believe, in cafeteria or something like that, because there's no beds. Next step is an elevator, I guess, where we put the bed. But do we need more beds? I personally, intuitively, believe that yes, we need more beds in Canada, particularly, because your average bed occupancy is higher than any industrialized nation. Whether it's US, in the US we have 2/3 bed occupancy pre-pandemic. In the UK, we have around 80–85%. So Canada is above 90%. So you definitely need more beds. But how many beds do you need and what kind? You ask this question at any hospital. Tell me how many beds you need. You need 3 orthopedic beds. You need 5 urology beds. You need 2 intensive care beds. You need 6 telemetry monitored beds. Ask them this question. If they need more beds, they should be able to answer. And each bed, by the way, in Canada, I might be not accurate, but I believe the capital cost of each bed in Canada is $700,000 plus several $100,000 annual operational cost. So you better know what do you need. How to find what do we need? How to find how many beds do we need if one day we occupied 50 beds, another day 30 beds, and another day 75. How many beds do we need? Put yourself in the position of the government. Imagine that you're coming to the bank and you want to borrow money. They will ask you 2 basic questions: how much and what this is for. You tell them, I don't know. How much they will give you. But we're in the same position. We tell the government, give us more beds. We do not know what kind of beds. We do not know how many exactly. We cannot say approximately 50 more, 50 less. 50 more, you're talking about 35 million in capital cost alone. So you better be accurate. But how can you be accurate? Let me ask you another question that would be easy to understand. What if I tell you that I'm going to pay you $1 million every year? I give you a paycheck for $1 million. And I would ask you, would that be enough? Most of you would say, of course. I would say, of course. I would say you're right with one caveat. If you stop gambling in the casino every night, because then it may not be enough. So the question is, in order to find how many beds do we really need and what kind of beds, we have to first learn how to optimally utilize them. So those peaks and valleys up and down are absolutely impossible to tolerate. And they would never allow us even to determine our needs, to determine the number of beds, to determine the number of nurses do we need. We have no idea how many nurses do we need either. We know that we don't have enough. And we do not know where is the stopping point either. So this variability is a key to the problem. So I told you that you could be placed in the wrong floor, in the wrong ward. I guess later on, you would be introduced by another person who has really suffered from this consequence. And her name is Helen Haskell. Her son, Louis Blackman, had a thoracic surgery that's supposed to be done on Monday. There was Halloween, and he asked his parents to reschedule it on Thursday. Oops, we know that on Thursday, the hospitals are full. So the boy had a very successful thoracic surgery, after which he has been placed in the oncology ward, pediatric oncology, because there was no bed in the thoracic surgical unit. And I don't want to steal, the story from her. That was her son, and she would be much, much better telling you about that.